Our next speaker is Dr. Suzanne Lentzsch, who joins us today from the Columbia University Medical Center in New York, where she is Associate Professor of Medicine and Director of Multiple Myeloma Service. Her presentation will focus on the importance of imaging in the diagnosis of management of myeloma. This presentation will be in English. Dr. Lentzsch, thank you.
Good morning, everybody. Thank you so much for having me here in Montreal, in that beautiful city. I would like to thank especially Aldo for that very nice invitation, very friendly invitation. Thank you so much for having me. A warning for the translator. So I don't know how that works, to have a German heavy accent translated into French. We will see. You will see a lot of things were already mentioned by the prior speaker, but I think as a patient, I hear that very often it's important that maybe you hear it from a different voice in order to better understand, things like staging and imaging. So I will give my best to not repeat what was said before and to bring something in new. Do you have a pointer for me, just in case? Alrighty, so. Perfect. Alrighty, let's go ahead and start. Okay, so today I would like to talk a little bit about diagnosis, how we make a diagnosis, and imaging is right now a very important part to make a diagnosis of multiple myeloma. I will talk about imaging studies for multiple myeloma bone disease, but also a little bit about what do we do with bone disease. For instance, surgical correction of vertebral fractures, but also how do we treat bone disease in general. That means anti-resorptive therapy. So I will talk about bisphosphonates and a little bit about future direction in the treatment of multiple myeloma bone disease. So how do we make the diagnosis of multiple myeloma? When you are diagnosed with a plasma cell dyscrasia or with a suspicion for multiple myeloma, it's very important to understand that we have three different categories. We have the MGUS, smoldering multiple myeloma, and overt multiple myeloma. MGUS, and I always tell that my patients, is not a cancer. This is something we have to follow because we find a small amount of an abnormal protein. We call that M, or monoclonal protein. It is usually less than 3 grams per deciliter. We can find a small amount of monoclonal plasma cells in the bone marrow, usually less than 10%. But what we don't find any criteria for overt multiple myeloma, that means we don't find any signs indicating organ damage from the multiple myeloma. We call that in English CRAB. I don't know how you translate that into French, but it's usually CRAB. You see that on the lower panel. I don't know when I show this, it only shows up there. Yeah. So probably it was mentioned already, the CRAB criteria. You see that here, CRAB criteria. C for elevated calcium, R for renal insufficiency, A for anemia, and B for bone disease. So if you don't meet any CRAB criteria and you have a low amount of a monoclonal protein or a low amount of clonal plasma cells, less than 10%, then we call that MGUS. If patients develop a little bit of higher monoclonal protein or plasma cells in the bone marrow, for instance, 12, 15, 20% of clonal plasma cells in the bone marrow, we don't call that MGUS. It is smoldering multiple myeloma. But as long as a patient has not any damage to the organs from the plasma cells, it's a smoldering myeloma, and we just follow it with wait and watch, so no treatment. So once you develop damage from the plasma cells, for instance, you have high calcium, renal insufficiency, anemia, or bone disease, then we call it active multiple myeloma and we start treatment. But you can imagine there was a little bit of problem. Usually the doctors watched their patients, MGUS, smoldering myeloma, and they saw that there is a decrease in the hemoglobin, or maybe that there is an increase in the creatinine. But it's very hard for the doctor to wait until you have really an anemia with a hemoglobin below 10, or until you are in full-blown renal failure. So there was a little bit of disconnect, and the doctors were really urgently waiting for some criteria to start the treatment earlier. And I think I pointed that out in red. We have, since 2014, 2 or 3 additional criteria to define active multiple myeloma and to start treatment. So that includes if you have more than 60% plasma cells in your bone marrow, if the ratio between kappa and lambda, your light chains, is more than 100, or if you have more than 1 focal lesions by MRI. And here you see the imaging. The MRI comes into the game to make a diagnosis of active multiple myeloma, to decide whether you need treatment, and to differentiate between smoldering myeloma. So in addition to the imaging tools we had so far, MRI really plays a big role. You heard before the international staging system for multiple myeloma. Patients very often ask me, doctor, which stage I am? And they probably think stage 1 differs a lot from stage 3. In multiple myeloma, again, we don't really make a decision on the treatment or about the treatment based on the stage. This is more a prognostic marker. The staging in multiple myeloma is, I would say, not of superior meaning. It's really more, is it a smoldering or an active multiple myeloma? So that's why I would say in general the staging is not of the relevance and does not really decide what kind of treatment you will receive. You also heard about the risk of multiple myeloma. Usually we decide between the standard risk and the high risk multiple myeloma. And what you can see especially is that the high risk is defined by abnormalities in the chromosomes. Again, the prior speaker talked a lot about the translocations, and you see, for instance here, when you lose certain chromosomes of the chromosome 17 or of the chromosome 13, you have a higher risk. Also, when you have a translocation, that means a switch of parts of the chromosomes from 4 to 14 or 14 and 16, you have a higher risk to not respond to treatment or to relapse earlier. So, but what about the imaging studies for multiple myeloma bone disease? So what you know and what we do, the good old skeletal survey, we call that metastatic bone survey, skeletal survey, and it's an X-ray of, I would say, all the long bones, the spine, the pelvis, and the skull. And what it shows is it shows lytic lesions. It is still the gold standard, and when patients are diagnosed or for multiple myeloma, usually all patients have a skeletal survey. 80% of our patients who have lytic lesions are positive in that skeletal survey. And that shows you that there's a problem. That means the skeletal survey, a normal X-ray, is in certain bones, especially in the spine or in the pelvis, relative insensitive. So you need to lose 30% of your bones at least that you show up as a, I would say, kind of lytic lesion or as a low density. Also, in addition, when we see response in multiple myeloma, the lytic lesions never go away. Once, I always explain that my patients, there's a hole in the bone, it doesn't heal. So that's very disappointing for patients, but that means that we cannot really use a normal X-ray to follow multiple myeloma for response assessment. What is much more sensitive is a CT. A CT scan shows you destruction of lytic lesion, of destruction of bone, when an MRI is even negative. And the nice thing what developed recently, especially in Europe, is that we do more and more a low-dose whole-body CT scan. That means we scan the patients from head to toe in 2 minutes without moving apart and without having several X-rays. So the low-dose whole-body CT scan shows us nicely lytic lesions in the bone and is very sensitive. And we can modulate the low-dose whole CT scan that patients have a low exposure to radiation, almost similar to an X-ray. So that method is usually very often used in Europe, but it's not that often used in the US. We do it at our institutions, but we hope that it comes from Europe and makes our detection for bone disease much more sensitive and also easier for the patient. So what about MRI? We hear more and more about MRI. So you see 2 pictures. The left one is a T1 weighted MRI and the right one is a T2 weighted MRI. So the MRI is not very sensitive for lytic lesions. What it shows you very nicely, bone marrow involvement of the multiple myeloma. It reflects more the tumor mass than a lytic lesion. And I mentioned already, before in one of my slides, then if you have more than one lesion by MRI, it counts as active multiple myeloma. And you can see nicely the lesions here, the white dots. Those are myeloma infiltrates, myeloma lesions. And you can see this patient has more than one, 1, 2, 3. I count at least 3. So that patient would have overt multiple myeloma. So, but there's a problem with the MRI. It's expensive. And when you ask your insurance, and that's also true in the States, you want to do a whole body MRI, the insurance will say, are you out of your mind? That's not possible. So what I usually do is I start with a skeletal survey in my patients. If it is negative, I do a CT scan of the spine. If it is also negative and I have a high suspicion that the patient might have multiple myeloma, then I do as a third method an MRI of the spine to see whether there are any focal lesions that allow me to make the right diagnosis. PET-CT, you heard about PET-CT probably for multiple myeloma. It's very often used in the States for the initial diagnosis. It is much more sensitive than the X-ray, and it has almost a similar sensitivity as an MRI. You might miss small lesions. The problem with a PET-CT is that it might show false positive lesions or disease in case there's any inflammation. So PET-CT, very elegant method, but very expensive. I'm not sure whether we can do a PET-CT as a gold standard for all patients, and especially initially and during follow-up. So we have really to fine-tune in which cases we need a PET-CT. How do we use those methods sequentially? I mentioned already, I think gold standard is still the skeletal survey, CT scan, and MRI sequentially in case you really need to make the diagnosis. In a patient who has multiple lytic lesions by a skeletal survey, I don't think it's really necessary to do an additional MRI, except there's any, I would say, suspicion for cord compression, and you want to see whether the nerves are compressed or not. So, but once you have lesions, lytic lesions in your spine, and you need to do more, for instance, you have severe pain or you want to make sure that there's no fracture, you can do some surgical correction for vertebral fractures, for instance. And many of you might have a procedure we call kyphoplasty. It's a procedure, very elegant, and it helps a lot to get rid of pain very fast. So what you do in this case, you insert a needle into the fractured vertebral body, and you can see that nicely here. I try to, yeah. This is a fractured vertebral body. You see there's decreased height in comparison to a normal vertebral body. Try the other side, you see the fracture here. So what you do is you insert a needle into the fracture, you inflate a balloon, you can see that there is an elevation of the end plates of the vertebral body, and you fill the balloon with cement, and that's why you stabilize the vertebral body. You get rid of the pain very fast. Patients have an enormous relief of their pain. It's an outpatient procedure, and really it helps to minimize the pain. Another similar procedure is a vertebroplasty. You also insert a needle into the vertebral body, as you can see here. Here is a needle. Try to show that at the other side. Yeah, take your. Here is a needle in the vertebral body, and you inject cement through the needle, and the cement also stabilizes the vertebral body. What this graph shows you very nicely is in green and in orange patients who received kyphoplasty, and in blue is a control group. Those patients only received pain medication, and it shows nicely the difference in the pain management. Patients who received kyphoplasty did significantly better, needed less pain, and had a better quality of life, and also a better functional status after the kyphoplasty. That slide looks complicated, but it's pretty easy. It shows you in orange patients who received the kyphoplasty, and it investigates the increase of the height of the vertebral body. And you can see in orange there's a substantial increase of the height of the vertebral body, especially in the thoracic spine, as you can see here. In the control group, you see a further decrease of the height, so there's a further compression. And this is especially, I would say, significant and striking in the thoracic spine, and not that much in the lumbar spine. Again, in orange, you see there's an increase in the height. So, but surgical procedure is not a procedure for all patients and only in selected cases. How do we treat bone disease after we imaged lytic lesions in general? Usually we give anti-resorptive therapy. That means bisphosphonates are still the gold standard for our patients with bone disease. And one of the changes is, I would say, 10 years ago, we started treatment with anti-resorptive therapy, that means bisphosphonates, once we detected lytic lesions. Today, we do that much earlier. Usually, when we make the diagnosis of multiple myeloma, of active multiple myeloma, at least the guideline in the United States is to start therapy or treatment with bisphosphonates. And there's a big debate which bisphosphonate is better. Is it zoledronic acid or is it pamidronate? And this slide shows you a direct comparison of pamidronate and zoledronic acid. And patients who experienced skeletal-related events, that means had a need for radiation, had a fracture, had a compression fracture, after 1 year. And you can see after 1 year, there is no difference between pamidronate and zoledronic acid. So you see that 46% of the patients receiving pamidronate and 44% zoledronic acid had skeletal-related events. So it really does not matter whether you receive zoledronic acid or pamidronate. The convenience is zoledronic acid is given in 15 minutes, pamidronate is a 2 to 4 hour infusion. So for the patient who receives that monthly, it makes a big difference. On the right-hand side, you see there's also no difference in skeletal-related events after 2 years. So again, both drugs seem to be potent, with zoledronic acid having more advantage in times of infusion. The problem with the bisphosphonates is they have one side effect we really don't like, the ONJ. I don't know whether you have heard about that, but it's osteonecrosis of the jaw. It's a really, I would say, a very bad side effect. You see that there's exposed bone in your jaw that can be infected, that can cause fractures locally. We saw that up to 10% after we introduced the bisphosphonate in the treatment of multiple myeloma patients, and we were really surprised, what's going on here, until we make the connection that bisphosphonates really increase the risk of ONJ, osteonecrosis of the jaw, from 3 to 10%. So, and why do patients develop this? First of all, remember the bisphosphonates, they really inhibit the osteoclasts. Those are the bone-resorbing cells in your body. If you lose the ability to resorb bone, probably you have a higher risk to develop infection and subsequently necrosis. And the risk factors are invasive dental procedures. So if you have any manipulation on your teeth, what I'm talking about, especially anything that affects the bone, for instance, a root canal or surgery on your roots, or for instance, a tooth extraction, that is something which is really can cause ONJ when you're on long-term bisphosphonates. Poor oral hygiene and also the duration, how long you get the bisphosphonates, are really important. How can we reduce the risk? We monitor the dental status, and what I do, and I think that's really important for you, when you start bisphosphonates, you should have your teeth checked. I usually send my patients to a dentist and say, make sure that you get an x-ray of all your teeth, that you don't have any infection ongoing, that you complete all your dental procedures, what is necessary, such a root canal, which you postponed for a long time, any really tooth that needs to be removed for a long time. That is important, and that really helps to decrease the risk of ONJ. Also, we try to avoid invasive dental procedures during the time you're on bisphosphonates, which is difficult. I mean, if you have a tooth that needs to be removed, you have to do this. So again, with all those measures, we really decreased the risk for ONJ from 10% to around 3 or 4%. So what do we do long term? When, in case you develop an ONJ, there's a nice study from Ashraf Badros, and he examined around 100 patients and followed them with ONJ. And he found that especially ONJ after dental procedures maybe has a better outcome. But what he also clearly stated was and showed that once you have an ONJ, the bisphosphonate should be discontinued. That is really important to allow a healing of the lesion. In case you had ONJ, the question is, you stop the bisphosphonates, can you restart bisphosphonates? That's a decision you should discuss with your doctor. I had a couple of patients who had an ONJ, it healed, they had active bone disease again, and we started bisphosphonates again in maybe a lower dosage or with a spread out interval. Again, that's something you should discuss with your doctor. In order to avoid ONJ, there's also a discussion, how much dose do we need? And can we decrease the dose? Can we maybe, instead of giving 90 milligrams of Pamidronate, 30 milligrams? And I have to say, those studies are not really liked by, pharma industry. I hope nobody is here, from Novartis. We will see. But I mean, there are studies that show that Pamidronate 30 milligrams are equivalent to 90 milligrams. That study, shows you. You see here the fracture score in patients receiving in blue 90 milligrams and in orange 30. And you see that there is no difference also in the skeletal related events. So what you can also do is you can discuss with your doctor when you have really active bone disease and you don't want to stop bisphosphonates, you are on that for a longer time. Doctor, is it possible to reduce the dosage? Alrighty, 10 more minutes. Oh my goodness, I have to hurry up. I do that, I have to say, I do that for the translator. I try to talk slowly because I think that will be a big mess. Talking in my usually New York style and then to translate, I think then you are lost. Okay. Yeah, okay, alrighty. Okay, MRC, I think that's a very important trial. It's a big trial that was performed in the UK. 2,000 patients were randomized to either zoledronic acid or clodronate. Clodronate is an oral bisphosphonate. I used it a lot in Germany 10, 15 years ago. We don't using it in the States. I'm not sure whether you use it in Canada. It's not really resorbed, but in the UK they are using it for patients and they compared that to the gold standard. And I think that was a very important study because what it showed was really that zoledronic acid, so IV bisphosphonates, are much superior. You see that in blue. You see that in blue, the clodronic acid has much more skeletal-related events. That means fractures, need for radiation, pain. That you can, with zoledronic acid, significantly decrease the, I would say, fracture rate, anything that is skeletal-related. So that's really a striking evidence that clodronic acid should not be given in patients with multiple myeloma. But what is really also important, they found an increase, and that was significant, in the progression-free survival. That means the time you live without multiple myeloma, and in the overall survival. So we think that those bisphosphonates, in addition to protecting your bone, also have an effect on the multiple myeloma and inhibit the growth of multiple myeloma. So that is another reason why when we start treatment for multiple myeloma, we also start bisphosphonates. Another study, and that's also interesting, and that was published by Nupa Raj in Clinical Cancer Research last year. So she tried to understand which patient maybe can have a spread out interval, and what she did, and that's very easy to understand. You see, she measured in the urine breakdown products of the bone. And she said, if you have a low amount of breakdown products in the bone, maybe I can spread the interval of zoledronic acid every 12 weeks. Patients who have high amounts of breakdown products, that means very active bone resorption, receive zoledronic acid every 4 weeks. And what she saw, that there was no difference in the outcome in patients receiving zoledronic acid every 4 weeks versus every 3 months. In case based on the urine markers. So that means what you can also do in case you have ONJ, you can discuss with your doctors, can you measure in the urine my breakdown products? And in case I have a low, I would say I have no evidence of high bone turnover, of an aggressive bone tumor, maybe we can spread the intervals and we can give zoledronic acid or Aridia, Pamidronate every 12 weeks instead of every 4 weeks. So that's another kind of option to really decrease the risk of ONJ. Denosumab. Denosumab is something that came on the market. It's a rank ligand inhibitor, and we know it inhibits also osteoclast activity. We were very excited to have a new drug, and we thought, okay, we have a new drug. It can be given in renal failure. It can be given subcutaneously. I don't have to care about the creatinine. That's a new drug which will make it very convenient for the multiple myeloma patients. So a large study was performed. You can see almost 2,000 patients with either solid tumors or multiple myeloma were randomly assigned to receiving either denosumab or zoledronic acid. So what we saw was, first of all, denosumab was equivalent to zoledronic acid. So that was very nice. But what we were really disappointed to see that the ONJ rate was similar. So our hope that we have less ONJ could not be fulfilled. But what was a problem was that the overall survival of patients who received Denosumab was inferior, was lower than of patients who received zoledronic acid. So subsequently, that drug did not receive FDA approval in the United States. So it is approved for breast cancer, but it's not approved for multiple myeloma. It is an option for patients who are on renal failure or have treatment-resistant hypercalcemia. But again, we were very disappointed and we hope to have an additional drug, but unfortunately we don't have. So renal function and use of bisphosphonates. In case your creatinine is elevated, it's a problem to use bisphosphonates. So we know that the maximum concentration of bisphosphonates in your blood is toxic to the kidneys. So what you can do in order to avoid the toxicity to your kidneys, you just spread the interval. Instead of 15 minutes, you take the zoledronic acid over 1 hour, 2 hours, and that makes it much more better tolerated for your kidneys. 5 minutes already. Oh my goodness, you know. So what do we do with MGUS or with smoldering multiple myeloma? Patients very often ask me, I have MGUS or I have smoldering multiple myeloma. Should I take bisphosphonates? Maybe I can prevent the development of lytic lesions. So far, there's no study that has shown that bisphosphonates, for instance, Iridia or zoledronic acid, can prevent development of multiple myeloma. And we don't recommend this. The side effects on your kidneys or the risk to develop ONJ are too high. We usually use this if you have osteopenia for other reasons. You know, then you can say, okay, take zoledronic acid once a year, like you would do that for osteopenia. But again, there is currently no role outside of clinical trials to use bisphosphonates for MGUS or for smoldering multiple myeloma. And I think I'm almost perfect on time. Future directions. I like this slide. It shows you the big osteoclasts, you know, and osteoclasts are giant cells. They eat and they resorb the bone. You can see in brown, this is the bone, and the osteoclasts are stimulated by the microenvironment, by the myeloma cells, by other cells, and they eat and resorb the bone. They move over the bone and they eat the bone. Again, for the other side, this is the osteoclast, and you can see here how the osteoclast is resorbing the bone. We have multiple targets we can inhibit to, I would say, decrease the activity of the osteoclast, and zoledronic acid, for instance, or bisphosphonates are only one of them. You can see there's, for instance, IL-6, MIP-1 alpha, VEGF, BAF. There are right now in clinical trials many drugs that target multiple myeloma bone disease. And when you see this graph, you see that bortezomib and IMiDs itself also have bone protecting properties. We know that bortezomib stimulates the osteoblasts, so the bone producing cells. That's a very nice side effect. And we also know that IMiDs inhibit the development of osteoclasts. So there's directly a decrease of the new formation of osteoclast. So, and that all leads to the, I would say, observation that bone disease right now is not that striking problem. We saw that 20 years ago where we really had bad fractures. Patients still have bone disease, but we are able to manage the bone disease much better, and we are able to avoid fractures in a much higher rate. So I would say there's a very positive development. So in summary, multiple myeloma is kind of, you know, the most common cancer involving the bone. Imaging and the detection of bone disease is critical to make the diagnosis. Remember, I mentioned already we start with a skeletal survey, with a simple X-ray. Then we can use a CT scan, PET CT scan if your insurance says yes, and MRI in order to make sure that we don't miss anything. Bisphosphonates are the gold standard for treating multiple myeloma-related bone disease. We assume that you have undetected bone disease in multiple myeloma at the time of diagnosis, so it's absolutely okay to start with bisphosphonates when you are diagnosed. And I think we have new insight into the pathology and development, how bone disease develops, and we have multiple targets and new drugs that help us to treat multiple myeloma bone disease much better. Thank you so much for your attention. I'm happy to take any questions.